Dear colleagues, good morning. We're going to go to the next session dedicated to 25 years of troponin. Most of you must remember at the beginning when after the first publications of troponin, nobody believed in this biomarker. And nobody imagined that after 25 years, troponin is the key for the diagnosis of myocardial infarction and probably is the most powerful indicator of risk, even better than electrocardiogram in many patients. To discuss about this topic, we have three excellent speakers. One is Jordi Ordóñez, very well known in our country. He is the director of a biochemistry department in Hospital Santiago in Barcelona, Autonomic University. The other two speakers is Professor Nick Mills. He's from Edinburgo, British Heart Foundation, Scotland, and also UK. And finally, the third speaker is Christian Miller, who is the director of cardiology department in the University of Basel, Switzerland. All of them have hundreds of publications, and many of them are dedicated to troponin, and I think we have an excellent excellent session to go for this topic, okay? The first presenter is Jordi Ordóñez, who is going to talk about biomarkers in coronary and acute coronary syndromes, a very long relationship. Jordi, go ahead.
Long and fruitful. So thank you, Mr. Chairman. Following your strict dressing code, I wear a tie, because Dr. Masip asked me to wear a tie for today. My aim, first, I would like to thank the organizers for inviting me to this meeting. And given that I have been followed during many years the evolution of the cardiac biomarkers and the diagnosis of myocardial infarction, other coronary diseases, and cardiac and extracardiac diseases, I will present you some evidence of the evidence that really it has been a very useful relationship that established between the clinical labs and clinicians. This looks as a very busy slide, but if we split in two parts, we can see at left in orange all the methodological developments that clinical laboratories were able to offer to clinicians for diagnosing myocardial infarction. So the relationship began as early as in 1945. But given the numbers of methodological development, it seems that we're not taking fully into account on the guidelines, principally the guidelines developed by the World Heart Organization, and we will comment why this happened. But if we look at the right side of this slide, it's just the opposite. Few methodological development and a lot of guidelines, a lot of universal definitions, rapid algorithms, one-shot strategies, new guidelines, accepting the use of high sensitivity troponins. So I also will try to explain you why happened. In fact, most of the cardiac biomarkers used in the past and still on use as creatine kinase or others were enzymes. On the modern enzymology, the first assay capable of measuring an enzyme in human serum was GOT, glutamic oxaloacetic transaminase, that is the same as aspartate aminotransferase. The assay was developed to measure GOT activity in transmural myocardial infarction, and it was shown a clear pattern of increase and decrease, rising up to 20 times during the first 24 hours after onset of symptoms, and are returning to normality in 3-6 days thereafter. This essay was published in a so-reputed journal as Science in 1954, but in 1959, the first WHO criteria didn't recommend the use of biomarkers, of any biomarkers, for diagnosis of myocardial infarction. Probably this was due because clinicians were not confident on the cardiospecificity of GOT, and they were true, obviously, but it's the only one we have at that moment. But it was important is that thereafter there were a lot of developments looking for the cardiospecificity, and the first cardiospecific or so-called cardiospecific enzyme was creatine phosphokinase. Creatine phosphokinase was developed by a genius, Dr. Rosalki, during a dinner in a conversation with the CEO of an American company that challenged Dr. Rosalki to develop a new cardiac-specific assay. And Dr. Rosalki did this on a napkin where developed the reactions that conduct to the assay of creatine phosphokinase. This was a great advance, but was still not introduced or recommended in the second WHO criteria launched in 1971. So the only true lesson that we can learn for this slide is that if you need something from a clinical biochemistry, it's easy. You should invite us to a restaurant, to a dinner, even a lunch is allowed, and we will develop for you ideas, protocols, methods, whatever you need. So this is a good lesson for all you. The next one was really the search for the Holy Grail. The Holy Grail seems to be at that time CK-MB, the most abundant isoenzyme of CK on heart, about 15–20% of CK, or the total content of CK in myocardiocytes, in cardiomyocytes, is CK-MB. And Robert Roberts developed an assay that was able to detect CK-MB not only in myocardial infarction patients, but also in patients without myocardial infarction. And this was very useful because it permits to differentiate patients with and without myocardial infarction rapidly in a shortened time that the use that they needed at that time, and the time was shortened to 12–24 hours. So this was very important to save time for diagnosis and even cost of patients admitted to a CCU without requiring so huge attention. But the assay was not fully applicable to all clinical labs, and a lot of developments follow the CK-MB first assay, trying to develop more rapid assays, trying to develop assays free of interference, the measurement of CK-MB mass or concentration, and finally, the development of the ratios of subforms that two CK isoenzymes, CK-MM and CK-MB, that were considered at that time the best and earlier biomarkers of myocardial infarction. But as Clinton says about the economy, we have to say this at that time, it's the heart. All these assays, all these biomarkers were not fully specific. And we are arriving to the time of troponins. Cardiac troponins developed that the karma exists, or show that the karma exists. At the end of the 70s, at the Massachusetts General Hospital. It was a postdoc training program trying to develop an assay for measuring myosin heavy chains as a rapid and inexpensive biomarkers of myocardial infarction. In fact, the myosin heavy chains radiolabel were used at that time to map myocardial infarction by image techniques. In 1982, Dr. Hugo Kaitus, that was involved in the program, but was German and coming back to Germany, developed a polyclonal antibody. Polyclonal is non-specific antibody against cardiac myosin light chains that incidentally detect cardiac troponin contamination of the preparation of myosin light chains Dr. Kaitus was using. So twofold. The antibody was not specific enough, and the antigen was contaminated with cardiac troponin T. So karma exists, because this led to the purifying of troponin T to generate anti-troponin T monoclonal antibodies. The hybridoma technique was developed at that time, and to develop a pilot immunoassay for measuring circulating troponin T, showing the advantages of troponins. Rapid increase from the usually low or even undetectable values, late peak concentration, biphasic release, and finally elevation during at least 2 weeks, 1 week or 2 weeks, depend on the troponin you are using. Cardiac troponin I was discovered in a more conventional manner by a group at the Washington University that has previously developed monoclonal antibodies against CKMB, myoglobin, and troponin I was the final consequence. But at that time, when these first assays were used in the clinic, and we are in 1992, so close to the 25 years, we observed that, or it was observed that patients without MI and chronic cardiac ischemic disease or not chronic cardiac ischemic disease have a huge difference in the percentage of positivities between CKMB mass and troponin I. Much more patients presented higher troponin I values or troponin T values than CKMB mass. So the conclusion for most of the journals of the time was that patient negative for CKMB, positive for cardiac troponin was a false positive of troponin. Fortunately, at the same year, Christian Ham, working together with Hugo Kaitus, present this paper, or present this study that was the prognostic value of serum troponin T in unstable angina. And Ham was able to show that all patients presented major adverse cardiovascular events after having anemia were positive for troponin, except one, and were negative for troponin, except one. So the sensitivity of troponin for detecting the future was largely better than that of CKMB. So no false positive, but true positive, not only for diagnosis and also for prognosis. So from here, something wrong. From here, we reach the right side of the slide, the cardiospecificity era. New MI definitions incorporating cardiac troponin plus analytical recommendations. These analytical recommendations led to development of high sensitivity assays. Let me say that a high sensitivity assay is an assay able to detect troponin in more than 50% of healthy subjects. The issue is who is healthy, but it's not the topic of my presentation, and able to measure the 99 reference percentile of a healthy population with less than 10% in precision. And with these methods, we are able to measure in nanogram per liter. With the contemporary methods, we are measuring hundreds or thousands higher values. And even one assay now under study is capable to measure picogram per liter. And this means detectability, because it's not analytical sensitivity as many people confund. The analytical sensitivity is the capacity of these methods to distinguish between two very close values. So to distinguish a significant delta. So having a good measurement of the P99 and having the capacity of detecting small deltas, we are able to develop rapid algorithms, one-shot strategies, etc., as my colleagues will show you next. So for finishing my presentation, a long and fruitful relationship, sure, the combination of an stethoscope and a blood tube has been productive. Cardiologists discover CKMB and troponin T, biochemists discover CK and troponin I. So in our hospital, Dr. Sionis and I have decided to merge our respective specialties and to create a new one that probably will be called cardiochemistry, that will be, produce fruitful results in the next future. So the combination is good, and it should be maintained. Thank you for your attention.
Thank you, Jordi. We decided to leave the questions at the end of the presentations. Next speaker is Dr. Nick Mills. He's going to talk about evolution in the diagnosis of acute coronary syndrome. Nick, it's your turn.
So thank you very much for the invitation. I'm sorry, Joseph, that I seem to have lost my tie along the Camino on my route to get here, but I hope it's okay if I can still present in the session. I've come from Scotland. I'm going to talk to you a little bit about the clinical perspective on this change that Jordi has outlined in the way that we diagnose myocardial infarction or acute coronary syndromes, and how this is evolving and continues to evolve in our clinical practice. These are my disclosures. So if you look at the history of the diagnosis, actually acute coronary syndrome is a term that was really only introduced in the medical literature in the 1990s, and it replaced a few other pretty dubious diagnoses. It's hard to know who to credit it to, but given we're in Santiago, I thought I'd give it to Spain. Valentin Fuster was the first to publish a really systematic review of what the acute coronary syndrome was in 1992. And he describes acute coronary syndromes as the constellation of patients with unstable angina, myocardial infarction, or sudden ischemic death. And this term arose out of a new appreciation of the underlying pathological mechanisms of acute coronary syndrome. This is by good work by Michael Davies, a pathologist in the UK, who defined 5 different pathological processes to explain patients who presented with acute ischemic pain. So Eugene Braunwald played a key role in the history of this syndrome because he was the first to attempt a classification. Now, back then, the diagnosis was largely based on clinical symptoms and a binary choice for a biomarker. So we have unstable angina, if the CKMB or troponin are negative, and we have myocardial infarction if there's necrosis. If you look at unstable angina, the classification is entirely based on symptoms. Did it occur post-myocardial infarction? Was it new onset angina? And to do with the timing of symptoms. If you have myocardial infarction, the classification is pretty straightforward. If the ST segments are up, it's a STEMI. If they're down, it's a non-STEMI. Quite a simple, logical classification, which is under threat due to the development of high-sensitive cardiac troponin assays. It's a disruptive technology. We've heard a little bit about the precision of the test. But the transformation really is that instead of just being able to measure injury to the heart during an acute coronary syndrome, we can now measure it in everybody all the time, irrespective of their symptoms. So we're starting to learn what it means. And out with acute coronary syndrome, troponin reflects a range of really important pathological processes. So transient reversible myocardial ischemia, hot plaques, vulnerable plaque in asymptomatic or stable patients. It's strongly related to atheroma burden, and it also reflects the downstream consequences of coronary disease, myocardial fibrosis. So if we're going to harness this information, we're going to have to rethink the paradigm of coronary heart disease. We've used biomarkers simply to categorize patients with myocardial infarction or no myocardial infarction in a binary fashion. And then we've used symptoms to classify the rest. But actually, coronary disease is complex, progressive, relapsing, remitting condition that starts early in life. And by the time you come to the coronary care unit with your first symptom, you've usually got multivessel disease and have had previous episodes of plaque rupture. So can high-sensitive troponin allow us to pick up this disease earlier? So what impact are these assays having on our clinical practice? Well, is the acute coronary syndrome evolving? So I have three pieces of evidence for you. First of all, a simple search of citations. We've lost interest in unstable angina around about 18 years ago. But the interest in myocardial infarction is growing as we're trying to understand how to use this diagnosis more effectively. Second, population statistics. This is in Scotland. I'm sure you have similar data available in Spain. But when we introduced troponin testing around about 2000, a little bit later than many countries, we diagnosed 10,000 patients a year in Scotland with unstable angina. Over the next 10 years, that's fallen tenfold. The acute coronary syndrome is definitely evolving. Third piece of evidence, clinical trials. So these are the key clinical trials that we use to guide our treatment for coronary heart disease in time order over the last 25 years. And what you find is the trialists aren't including patients with unstable angina either. And that's because they know their prognosis is uncertain or good, they don't have events, and because there are fewer of them. The only exception, I think, is the Trilogy ACS trial, where they did have a significant proportion of unstable angina, because it was conservatively managed patients with acute coronary syndrome. They're hard to recruit. Okay. So has this evolution in the diagnosis made any impact on patient care and outcomes? Well, we looked at this in Scotland a few years ago, not with a high-sensitive test, but with a contemporary sensitive assay. And I think proof of concept, really. Lowering the diagnostic threshold from 200 to 50 using a more sensitive test led to better outcomes. During the validation phase of this assay, these patients with undisclosed, unreported injury below our threshold for diagnosis had pretty poor outcomes. After we introduced the test into clinical practice, we saw a 50% reduction in recurrent MI or death, just purely by introducing this test into clinical practice, because they got better treatment for coronary disease. But high-sensitive tests, will they have the same impact? Improvements in sensitivity are inevitably going to lead to reductions in specificity. And therefore, it's a little less certain. And actually, if you look at the latest guidelines on the classification, acute coronary syndrome is only mentioned once as an abbreviation at the front of the document, and then they forget to mention it in the rest of the document. It's all about how you classify patients with myocardial infarction now. And they recognize that there are many mechanisms and that we have to differentiate between patients with plaque rupture and coronary thrombosis, type 1, from those that have myocardial infarction or injury as a consequence of other conditions. But I wonder if Eugene Braunwald's very logical statement from the earlier guideline is still being adhered to. The purpose of classification is to establish prognosis and define how to treat these patients. I'm not sure we are certain about these aspects yet. So when we introduced high-sensitive testing in Scotland, we did this as part of a step wedge cluster randomized trial, because we weren't certain whether the benefits of sensitivity were going to lead to better targeting of treatment and better outcomes, or actually poor specificity would lead to inappropriate therapies, investigations, and harm. We have 54,000 consecutive patients enrolled in the trial, and we hope to report at the end of this year the outcomes. This trial is delivered through a screening, enrollment, the intervention, and follow-up, all using a system that's embedded into our electronic patient record. But we do adjudicate all the index diagnosis and all the outcome events, just the way you would in any more conventional trial. So what have we learned through doing this along the way, this trial? Well, the first thing is that high-sensitive troponin assays do increase the diagnosis of type 1 myocardial infarction. Most of those increases are in women if you apply sex-specific thresholds, 16 for women, 34 for men, such that the proportion of men and women coming to hospital suspected acute coronary syndrome who are diagnosed with myocardial infarction is the same. Second, other causes of myocardial injury and infarction are extremely common. In fact, they're more common than type 1 myocardial infarction, particularly in older patients. Above the age of 75, you're much more likely to have another cause of your myocardial infarction than plaque rupture. And third, these patients have very poor outcomes. So at 5 years, all-cause mortality in patients with type 2 myocardial infarction or myocardial injury where there's no evidence of ischemia is 70%. Of course, many of these deaths occur early due to their alternative clinical condition that precipitates their hospital admission. And if you do a landmark analysis, so if you survive your index hospital presentation and you take into consideration competing risk from death due to non-cardiovascular conditions and look at the MACE rate, there's no difference in recurrent type 1 myocardial infarction or cardiovascular death, whether you're classified as a type 1, type 2, or myocardial injury. So this classification is failing one of the important criteria, which is to establish prognosis. If you drill into this in a little more detail, those patients who've got either type 2 myocardial infarction or myocardial injury who have coronary heart disease have the worst outcomes. If you don't have coronary heart disease at the time you present, your outcomes are a little better. But there's a clear treatment gap between patients with type 1 myocardial infarction and type 2 myocardial infarction with coronary disease. And I think as cardiologists, we need to think carefully about how we manage these patients. So I think the future of acute coronary syndrome and how it evolves is increasingly going to be reliant on imaging. We've gone from symptoms and ECGs in the WHO to a key role for biomarkers. But invasive and non-invasive imaging is going to become critical to the way that we define acute coronary syndrome. And I thought I'd give you a couple of cases just to illustrate this point. So this is an 84-year-old who presents with a 3-day history of breathlessness, cough, and fever. But the day he attended, he had some central chest pain. He's a smoker with hypertension, and he's on treatment for angina. He's got a tachycardia, a fever, and he's a bit breathless with some wheeze and crepitations. And his cardiac troponin, high-sensitive troponin, is 700, so 0.7 micrograms per liter. Well, what is your clinical diagnosis here? What would your clinical diagnosis be in this setting? He's got left bundle branch block as well. Okay, all right. Pneumonia and acute myocardial infarction. All right, and what would your universal definition of myocardial infarction diagnosis be? If you had to classify according to the universal definition, Christian.
Again, I agree with you. It's useless. I think it's type 1 underlying.
Okay. So we are asking one of the most expert cardiologists on this topic. But yeah, so you would classify this as type 1. So the guidelines would probably suggest it's type 2 because they've been hypoxic and tachycardic, and they have what appears to be a fixed obstructive lesion in the LAD, and also a chronic occlusion of the right coronary artery. This is quite an ischemic LAD territory. But my point, I suppose, was that the imaging is increasingly helping us to clarify the diagnosis. This is intraoptical imaging of that LAD, and you can see clearly disrupted plaque with evidence of thrombosis within that lesion. Okay, so Christian indeed is correct. This is a type 1 infarct due to plaque rupture, coronary thrombosis in the context of a chest infection. But many cardiologists, certainly in my hospital, would just ignore that referral and say this is pneumonia and don't worry about it. But the truth is, systemic inflammation triggers plaque rupture. So here's a second case. 62-year-old male presents with a history of intermittent severe chest pain at rest. No risk factors for coronary disease, recent diagnosis of asthma, observations pretty unremarkable. This is the ECG. What's the clinical diagnosis here? No, I'm not.
I think it's an MI.
An MI, okay. Yeah, okay. This is not meant to be a trick at all. It's an MI. What type of MI? Thinking of the logical classification that we had 20 years ago?
Well, it looks like an ST elevation.
ST elevation MI. Okay, very good. Right, this is the coronary angiogram. The right, I haven't shown you the left, which was quite normal. What was the universal definition of MI classification here?
Can't see the RCA very well, but it looks like there is a tight lesion.
I'm sorry, it's not projecting very well. Yeah, there's very severe diffuse disease there. I don't know why it's so dark. Okay, but the point is that actually when we did the procedure, it was all vasospasm. So there's a lot of ring down on the optical coherence tomography catheter, but a little bit of neointimal thickening, but no atheroma, no plaque rupture, nothing. So the universal definition of myocardial infarction classification here is type 2 myocardial infarction due to vasospasm. And if you look at the angiogram again after some intracoronary nitrate, and I think I might just have broken the system. Yeah, I don't think I can show you that. I might be asking too much. Here we go. Then the artery looks pretty normal. Minor irregularity, so just medical therapy.
So what was his troponin?
His troponin was high. I can't remember, but it was significantly raised, hundreds if not thousands. But there's a bit of a disconnect between the clinical diagnosis of STEMI and the classification that the guidelines are telling us to use. But the treatment does differ. Now, what about unstable angina? Can we now banish this completely, but back to the history books, along with acute coronary insufficiency? Unstable angina has had its day. Well, we've had a look at this with Christian. This is just the data from Edinburgh that we've been working on. This is the first 5,000 patients in the trial, and the adjudicated diagnosis of unstable angina was just under 3% in our cohort. So we still made a diagnosis. So it hasn't gone completely. And if you look at the characteristics of those with type 1 or non-STEMIs and unstable angina, they're pretty similar. If anything, there's an excess of patients with a known history of ischemic heart disease. And I think that's interesting because patients who present with acute chest pain who are known to have coronary disease, clinicians are very reluctant not to attribute that pain to angina. But their troponin concentrations are pretty reassuring. I had to look pretty hard to find a good case for you. This is the best one I could find. No, doesn't want to show you. So this is a 68-year-old male who presents with severe angina at rest over a 2-week period. Oh no, there you go. He's known to have coronary heart disease already, hence the diagnosis of unstable angina. The ECG is pretty unremarkable. And troponin concentrations were within the normal range. A little higher, but not clearly changing, if anything falling. And this was adjudicated as unstable angina on the basis of this severe lesion in the circumflex. But my feeling is that this is a failure of the patient to present at the right time. This would have been a myocardial infarction if he'd presented 2 weeks ago when he had his plaque rupture acute coronary syndrome event. And it's because he's delayed presentation for 2 weeks that we're classifying this as unstable angina. Okay. So what we've learned is that the lower your troponin concentration, the less likely anything bad is going to happen to you. And if your troponin concentration at presentation to hospital is less than 5 nanograms per litre, well within the normal reference range, then the chance of having a myocardial infarction or a cardiac death at 30 days is low. The negative predictive value of this test is in excess of 99.5%. This isn't just a phenomenon that we've seen in Scotland. Many of my colleagues and collaborators have done similar studies and shown similar things, and we all got together and we shared our data across cohorts with a wide difference in prevalence of the diagnosis. This is almost 23,000 patients from 19 cohorts. And we showed exactly the same thing. If your troponin concentration is very low, using a high-sensitive test at presentation, the chance of something bad happening is also very low. Around 50% of our patients with suspected acute coronary syndrome fall into this category. And at 1 year, 1 in 1,000 of them died from cardiac death. It's a pretty low risk. So I would challenge that the diagnosis of unstable angina is not compatible with having a high-sensitive troponin concentration below a risk stratification threshold. I don't think you can have any of these mechanisms that we know define acute coronary syndrome with a troponin concentration below this level. And I think the universal definition, which attributes only one line to the diagnosis, maybe needs to work a little bit more on how we classify this condition in the future. And one last thing. People always ask me when you should retest troponin after patients come to hospital. Should it be 1 hour, 2 hours, 3 hours? When do you measure it again? So I can now definitively answer that. You should measure it again 4 months after they come to hospital. And the reason for that is that if you measure it when they come back to your clinic, and this is 2,000 patients with an adjudicated diagnosis of acute coronary syndrome, if troponin concentrations have fallen back below this risk stratification threshold when they come back to your clinic, over the next 10 years, they're extremely unlikely to have a cardiovascular death. If troponin concentrations remain above the 99th centile, so this is around 10% of the cohort at 4 months, then they have a substantial excess risk, a 7-fold increase in risk of cardiovascular death over 10 years. So in terms of how to optimize treatment and think about who we can rationalize treatment in, I think this is the time to measure high-sensitive troponin when they come back to the clinic. So I'll finish there, just thanking the team and collaborators. Thanks.
Thank you, Nick, for this excellent presentation. And thank you also for putting some imaging from Santiago. Next speaker is Professor Christian Miller from Basel. He's going to talk about high sensitivity cardiac troponins as biomarker of stable cardiac ischemic disease. You know that he has been working in the rule-in, rule-out acute MI, but now he's moving to a chronic state. Christian.
Okay, so dear Josep, dear Alessandro, thank you for giving me the chance to come again to this wonderful meeting. And Alessandro has given me a provocative title to cover, and as I think Nick has been provocative, highlighting some of the new concepts, I try to stay the same. So may I ask you to raise your hand if you, within the last, let's say, 2 or 3 weeks, have tested cardiac troponin in patients presenting with acute chest pain in the emergency department or chest pain unit? So who of you did tested troponin in the acute setting? So nearly all of us did. So who of you did test for high sensitivity troponin when you were considering stable coronary artery disease as the cause of symptoms, as a potential alternative to imaging? Did any one of you, please raise your hand if you did test high sensitive troponin when considering this as for stable? What's different story, however, but stable, none of us did. Okay, so the task now is to highlight the potential, but also, of course, of the current limitation of this novel or provocative approach. Again, of course, my potential conflicts of interest. As I do clinical research, I have support from mainly public organizations, but like Mill's collaboration with several companies. The most important disclosures, not on this, but on the next slide. I have a wonderful team to work with, and I'd like to acknowledge and highlight their fantastic support in all of our projects. That's how they look like when they work hard in Basel, and that's how they look like when they party during one of our last team events. The hypothesis between the potential use of this novel high sensitivity troponin in the evaluation of stable coronary artery disease, stable in parentheses, is that likely a relevant proportion of patients that when diagnosed on clinical grounds we think are stable, they may have coronary microembolization, tiny amounts of either plaque material or thrombi that go into the distal periphery, and that cause tiny amounts of cardiomyocyte injury. So if this is true, then patients with so-called stable coronary artery disease, because they then have some tiny amounts of cardiomyocyte injury that can be quantified by high sensitivity troponin, they should have higher concentration than, for example, patients who present with similar chest pain symptoms but do not have underlying coronary artery disease. So similar, if that's true, then this biomarker that all of us only currently use in the acute setting might offer some help to use cardiac imaging, which of course, as indicated by Nick, is a very important player in our diagnostic armamentarium. Potentially, the indication that might be most close to clinical acceptance is that, again, if the concentration of high sensitivity troponin, if they are very low, then it's unlikely, very unlikely, that the patient does have functionally relevant coronary artery disease. And functionally relevant to me as a clinician means that either the patient does neither have symptoms related to the disease nor clinical events within the next years related to the disease. And that concept is very similar to what all of us use, again, in our daily practice when we consider patients with suspected pulmonary embolism. For the diagnosis or rule out of pulmonary embolism, we use the combination, again, of imaging and biomarkers. And the biomarkers for pulmonary embolism is D-dimers. So if the clinical pretest probability is not extremely high, then we do D-dimers, and if the D-dimers are negative, we are done. If the D-dimers are high, then of course we have to proceed to imaging and either diagnose or rule out pulmonary embolism. But what is our daily clinical practice when we consider stable coronary artery disease? We heavily rely on imaging in all our patients, like a SPECT that is commonly performed in Europe. So the imaging procedures, even the most expensive and best ones, they achieve a sensitivity of about 95%. And so the concept and the aim of our research, of this research project, is to see whether we could use very low high sensitivity cardiac troponin I blood concentrations to rule out functionally relevant CAD without imaging, achieving the same sensitivity as the expensive but nice imaging procedures. We did this within the Basel 8 study, which has the advantage of unselected referral of patients with suspected coronary artery disease. It has a very strong methodology to adjudicate the presence or absence of functionally relevant CAD, and in this setting it's the largest study worldwide. And similar to the work that Nick did and Jordi and Alessandro, we used the single-X troponin I, which currently is the assay that has the highest sensitivity and the highest precision for very low concentrations. And the first step was to use their experimental assay. The aim was, again, to test the value for the rule out of functionally relevant CAD in patients, of course, who did not have known coronary artery disease. And the second aim was then to derive a cutoff level that, again, would achieve this 95% sensitivity. So again, this is the reference standard. Imaging, including coronary angiography if it was done, and the investigational test is simple clinical judgment done before and after the exercise test, and the blood test done before the exercise. So we excluded patients with known coronary artery disease or other relevant cardiac disorders, leaving about 700 patients. And in this cohort, we were able to show that, similar to what was the hypothesis, patients with functionally relevant coronary artery disease and myocardial ischemia do have significantly higher concentration as compared to those patients without functionally relevant CAD. All patients did have detectable levels, so detectable is very different from elevated, and nearly all of them had concentrations in the normal range. So the 99th percentile of this assay is about 10, so all is below the threshold that is chosen to diagnose acute myocardial infarction. So this has nothing to do with acute myocardial infarction. Stable patients, those with disease having higher concentration as compared to those without disease. Of course, for a diagnostic test, you have to quantify the diagnostic accuracy by the area under the curve. Our clinical assessment prior to exercise is this line, 0.64. The biomarker on its own, 0.7. And of course, what we would do to combine the biomarker with clinical assessment results in the green line and in a moderate diagnostic accuracy of 0.73. Then, of course, we need to select cutoff levels for the decision to rule out functionally relevant coronary artery disease. And for this experimental assay and using serum as the matrix, we found that concentrations below 1.5 nanograms per liter, so very, very low concentrations, would provide us a very high sensitivity, similar to those of the imaging test, and allow to rule out the disease in 15% of patients. That was with the experimental assay, and of course that was interesting, but how could we use this in clinical practice? So in clinical practice, now the company has developed a clinical platform that again Jordi, Alessandro and Nick also work with since a couple of weeks, and using plasma, as plasma is the preferred matrix for most of the clinical applications. So the next aim was to see whether the same would work using the clinical platform and using plasma as the matrix. And again, of course, we want to be as good as our expensive colleagues doing imaging, achieving sensitivity of 95% or higher. Again, we found the same thing, similar performance if you do it with the clinical platform, and again, overall moderate accuracy in the application study with some improvement in diagnostic accuracy by combining the clinical assessment with the biomarker. The plasma levels were slightly lower, so again, the cutoff level to achieve 95% sensitivity for plasma was concentrations below 0.5 nanograms per liter. So again, extremely, extremely low concentration. If the patients have extremely low concentration, they do not have functionally relevant coronary artery disease defined by imaging, like a myocardial perfusion scan and coronary angiography, but also, and I think that's important, they also do not develop events. So this is for the diagnostic evaluation, but now doing the same, applying this cutoff for prognosis. So would the patient that has some exercise-induced chest pain, would he or she develop symptoms? If you use this cutoff, if the patients are below this cutoff, so again having very low concentrations, they do not develop events defined as cardiovascular death or acute MI, and if they have concentrations that are higher, then a relevant number of events does occur. Again, linking cardiomyocyte injury detected using high sensitivity cardiac troponin I with clinical events and our kind of therapeutic strategy for patients with coronary artery disease. So the conclusion of this phase of Basel 8 were that the high sensitivity cardiac troponin I concentration at rest provide incremental value to clinical judgment in the rule out of functionally relevant CAD. So very, very, very low concentration allow us to be as good as our imaging colleagues and provide a sensitivity of 95%. And for the platform that we have clinically available now since a couple of weeks, it's plasma concentration below 0.5 nanograms per liter. It's simple, however, it works only in about 10 to 15% of patients. What remains to be done at this point in time, of course, is external validation. So we have validated internally, but all of our research finding can only be really considered mature enough if other groups can reproduce our findings, and we need to increase the efficacy. Fortunately, the first kind of on the to-do list has already been achieved and done by Nick and his group. So Nick did a very similar study, but not using a functional imaging test like myocardial perfusion scan as their gold standard, but coronary computed tomography. And if they, in their cohort, then looked at what are the differences in patients with extremely low concentration, again, using the same assay that we had used, or patients with higher concentration, there's a clear association between the calcium score, again, highlighting coronary anatomy, and the presence or absence of coronary artery disease in imaging. So again, if the troponin concentration is very, very low, patients are extremely unlikely to have relevant, defined by anatomical means, obstructive coronary artery disease. And again, the second figure nicely showing that it also impacts on their risk prediction. So they used a model depending on age and the type of chest pain to define the likelihood for obstructive coronary artery disease, and you get the red dots just by the model, and depending on what troponin concentration the individual patient has, the risk actually gets lower if the concentration are lower, or it gets higher if the concentration are higher. Again, indicating a possible role of using high sensitivity cardiac troponin I in the evaluation of patients with stable coronary artery disease. Mr. Chairman, dear colleagues, I'd like to conclude this presentation by indicating to you this is very, very early on. I have realized none of us has ever used this test as part of clinical routine, but I think the rationale is quite strong. And I think this is likely something that we will have available and should consider for clinical use in the near future. So we have done some of our homework. We can use the tool, and if the concentration is, again, extremely, extremely low in a proportion of 10 to 15% of patients, we can rule out the presence of disease, as well as we can rule out the likelihood that clinical events will occur within the next years. The next step that we still have to achieve, we have to increase efficacy. We have to consider how we can increase the number of patients that can be ruled out by the biomarker approach combined with clinical assessment. Thank you very much for your attention.
Thank you, Christian. Now the speakers, can you come? It's time for questions. When you are thinking about questions, let me tell you something that in Spain, it is very common that people refer to the troponin as a troponins in plural. And this is very common in emergency room and also in intensive care. I think less in cardiologists. And Jordi, after 25 years, which kind of troponin you think that is the winner, is the most used in the market currently? Troponin I, troponin T?
So it's a very challenging question. There is only one provider of troponin T, at least in Spain, because the other providers are not introduced in our market. And there are many companies selling troponin I. I think that is approximately 40%, 30-40% for troponin T, and the rest for troponins I, but different troponin I's. But I think that the use of the term winner is not fully correct. So the winner is the best troponin you use in your lab with your protocols, in agreement with the clinicians, with the EDs, and in order to obtain the maximum efficacy. So in this regard, all troponins provide the same efficacy when used correctly.
Perhaps I'm just to add to your last statement, I'm not sure whether that's really true. So I think it's important that each of you get to know the assay that you are offered by the lab and apply it as good as possible. And there are differences, there are definitely differences between assays that are currently on the market. And you cannot, for example, you cannot use all of the assays on the market for the protocol that Nick introduced to you with concentrations below 5, because many of the assays just cannot measure in this range. And you cannot use a 1-hour protocol with some of the assays on the market. So you have to know your assay, and only those that are really high sensitivity offer the opportunity that were highlighted by Nick for the acute MI diagnosis. I think that's a very important message, and you miss patients with myocardial infarction if you do not have a good troponin assay in your ED.
And
Excuse me, perhaps your question was very general, so I can point my answer. Now there is a coexistence of contemporary troponin assays and high sensitivity assays. The troponin T assay, the only troponin T assay market in Spain, is a high sensitivity assay. Can be denominated high sensitivity assay. Now it is also being marketed. I will mention brands, companies. Agudos is measuring high sensitivity troponin I. Regardless, they're still offering the contemporary assay. And now, recently, Siemens has incorporated the high sensitivity assay for the marketing. But in a recent poll we conducted in Barcelona, in all the centers attending patients suspected to have an MI, I have to concur with Christian that many of the clinicians didn't know what kind of troponin they were using. T or I, they were not, and sometimes even if it was contemporary or high sensitivity assay, there were no protocols in several centers, not obviously in the university hospitals, and there is a lack of communication between the lab and the clinician. So I should to point out, the first is, as Christian mentioned, to establish a relationship between the lab and the cardiologists and ED physicians and say, okay, boys, we're using this assay, the 99 percentile is this, the delta is considered whatever, but having a protocol and a mutual acknowledgement.
So I have a quick question about using cardiotroponinis in the setting of stable patients, as you mentioned. So you said very provocatively. So the second troponin should be measured at 4 months. But are you currently doing this in your practice? Do you measure troponin in your stable patients? And I think the big problem here is that if you have an asymptomatic patient with good functional status with a high-ish troponin, not diagnostic of myocardial infarction, but high-ish troponin, the problem, and you have with all the treatment is supposed to be on and everything, it's kind of frustrating because you don't have really much left to do with the patient, and even though you recognize that he has high risk.
So that's a great question. I am measuring it quite often in the outpatient clinic, but that's because I enroll as many of my patients as I can into clinical trials. My hospital isn't funding the test in the outpatient clinic at present. That's the truth. We still need to convince, I think, the guidelines and the healthcare system that this is a valuable tool. But I think it is really valuable. And you make a good point. a little frustrating if you feel you've got your patient on optimum treatment, they've had optimum revascularization, and they've still got myocardial injury. But actually the majority of patients don't have optimal treatment and haven't been fully revascularized and haven't had proper assessments of their left ventricular function when they come back at 4 months. If 1 in 10 still has myocardial injury, levels above what we would consider diagnostic of myocardial infarction in a different setting, they're very high risk, and we need to do everything we can to optimize that risk. But I think clinical trials are required to tell us what treatments to use. It is likely to be a composite of maybe recommending prolonged antiplatelet therapy if they haven't been fully revascularized, maybe looking carefully at their left ventricular function and determining whether you really have them on optimal treatment for left ventricular remodeling and to prevent heart failure episodes in the future. So I think there's a lot we could learn if we opened our eyes and tested.
But also in the chronic scenario, I think that the different approach when you use this as a diagnostic marker in symptomatic patients that you really don't know if it is angina or not, I think this is a group of patients when it could be useful. And the other scenario is patients with well-known coronary artery disease. In this case, it's more for increase the treatment, or is more prognostic or high-risk marker than in the other population. Is it true? Yeah. And I have also a question, because many years ago, we classified patients in acute MI or unstable angina. In patients with acute MI were Q or non-Q acute MI. And now is a STEMI or non-STEMI or unstable angina. Unstable angina are very few patients. Most of them are STEMI or non-STEMI. And we have a huge number of patients with acute MI with a completely different, Q waves on all the precordial leads or just minimal changes. Do you think that we need perhaps new definitions, or at least to differentiate these patients according to the size of the myocardial injury?
Yeah, I think it's a great point. We've had the ECG for over 100 years, Nobel Prize winning technology, still used every day, fabulous. But we have better tests now for assessing whether a Q wave is relevant, including cardiac MRI and echocardiography. And I think that the way that the evolution of this diagnosis is going is that we're using these technologies to classify patients better. So your presentation was a type 1 myocardial infarction with ST segment elevation. Whether you have a Q wave or not, it's not relevant. What's relevant is whether you've got left ventricular systolic dysfunction. And therefore, I think our diagnostic when it comes to looking at the complications of myocardial infarction, it's important to classify and document them well as also, if that answers your question.
Okay, now I think it's time for finishing the session. Thank you for the speaker for this. No, the last, Jordi.
Given that that most of the attenders are Spanish, I think that is relevant to talk about the cost. I have attending the sessions of the IP, C, K9, troponins are in cost of euros, roughly arriving to 10 euros. So consider the cost of an echo, an image test, the need of a cardiologist interpreting the echo. So is available 24 hours per day, no vacations. No? So I think that you should be more users of troponin in order to gain insight in your patients, because it's a cost that is perfectly assumable by the health system.
Of course, you are a fan of biomarkers.
Yeah, no, high sensitivity troponins are only a few development that it is the same cost. So Yes,
Last word.
Just a quick point and then a question for the audience, if I can. I completely agree. I think troponin as a screening tool to identify those that need expensive and more detailed imaging tests is absolutely the way to do it. But I wanted to ask the audience to put your hands up if you think troponin, 25 years later, it's been a good development or not. Hands up if troponin's been a good thing. Whoa. Okay, of those that are still with us, keep your hands up if you think high-sensitive troponin has been a good thing. So all the same people, keep your hands up. How many of you would consider measuring high-sensitive troponin in your outpatient clinic as a consequence of what you've heard this morning? And for chest pain, query, angina? Okay, so still we've got a little bit of work to do. That's been useful. Thank you for your thoughts.
Thank you very much.